Hello, everybody. I'm JP Hong from Seoul, Korea, and it is a pleasure and an honor to be part of the OSCON meeting in Croatia. I know that this meeting is focused on learning especially for students and young physicians. Today, I would like to talk about the topic on lymphedema and how it is being translated from the basics of understanding the physiology, pathology, and now implementing with these knowledges and how we could find solutions to help these patients with lymphedema. In our body, all the nutrients are delivered by the artery and then absorbed back into the vein through the capillary process. In the capillary, the artery sends out fluid, nutrients to the extracellular space where the cell absorbs these nutrients and oxygen and uses it and then excretes um, from the cells like CO2, and then it absorbs into the capillary veins and then ultimately to the larger vein. Now, this typical flow of fluid from artery to the capillary and then to the vein is responsible for around 80% of what is given from the artery. The rest of the 15 to 20% of the fluid is then absorbed by a third vessel, which is also known as the lymphatic vessel. Now, these lymphatic vessels are collected very near the skin, and then it drains to a little bit larger lymphatics, and then ultimately to a very larger, sizable lymphatic vessels in the subcutaneous fat. So in reality, you see these superficial collecting lymphatics, and that drains a little bit more into the deeper collecting lymphatics. And these are often the targets to do lymphovenous anastomosis, which we'll be talking about later on. Now, these lymphatics travels throughout our body, goes through the lymph nodes, and then ultimately it drains to the thoracic duct. So this whole body of a network of the lymphatic vessels throughout our body ultimately goes into the larger lymphatic vessels, travels the lymph node, and ultimately drains to the vein. So these fluids are then replenished 100% and goes through the arterial system to flow to complete the circulatory system once again. And if you look at these lymphatic a little bit closer, it is a hybrid form of artery and vein because it has smooth muscle cells that actually contracts the vessels. And at the same time, like a vein, it has valves. So these valves prevent the lymphatic fluids from sliding backwards and ultimately causing swelling. So in a way, it has the both a characteristic of an artery and vein. Now, what is also important to know is that it not only has an intrinsic perivascular smooth muscles to squeeze the lymphatics toward the heart, but also our muscles, when we exercise or when we contract our muscles, the muscle also pushes the lymphatic vessels and helps to propel the fluid toward the heart as well. So the delivery of the lymphatic system is intrinsic as well as extrinsic forces help ultimately for the lymphatic fluid to deliver to the heart. And this is why in early patients with swelling, who's been diagnosed or who's not been diagnosed with lymphedema, this is why they're asked to use compression, because the compression, when the muscle contracts, instead of exerting the force outward, it exerts the force inward and helps to contract the lymphatics more. And this is why a lot of the conservative care is built around the idea of using that extrinsic focusing on that extrinsic force, and thus recommend a lot of compression and exercise for early lymphedema patients. Now, again, the lymphatics travels throughout our body. It passes through multiple lymph nodes in our body. We have more than 500 lymph nodes, which we'll be talking about in detail later on, because we also utilize these lymph nodes to actually transplant the lymph nodes back into the place of where the lymph node has been missing or the lymph node has been resected to recover the lymphatic system. And ultimately, these lymphatics, after passing the lymph node, again, goes in to the right and left subclavian vein, and ultimately adding that fluid to 100%. So the key question in lymphedema is to actually ask, where is the site of obstruction? So you can easily imagine in breast cancer, for example, they will remove the lymph nodes in the axilla to minimize the spread of cancer. So what happens is when you remove the lymph node from the axilla, the lymphatic pathway is abrupted, cut, in the axillary region. And this is why the flow from the arm, which goes through or drains to the axillary lymph nodes, gets obstructed. And this is why it's causing lymphedema of the arm. And the same principle applies for gynecological cancer when they remove the intrapelvic nodes. And then because of the obstruction in the intrapelvic lymphatics and the enlargement or the swelling of the leg occurs. So using this idea of understanding where the obstruction is, let's take a quick look at this patient with chylothorax. And you could see the fluids accumulating in the pleural cavity. Now, the problem with this patient was that this patient was young. He had a congenital agenesis of the kidney, and they use the subclavian vein to use it as a hemodialysis port. Now, however, because of the multiple change, the subclavian vein ultimately got injured. And because the subclavian vein got injured, it obstructed the pathway of the lymphatics that needs to drain to the vein. And this is why you could see clear dilation of the lymphatics system in the abdominal chain and dilation of the lymphatic vessels. And ultimately, the weakened lymphatic system in the pleura started to leak and ultimately create a pleural effusion or chylothorax. And this is why it's important, because when it's obstructed, what happens to the vessel is that it starts to dilate, and then it starts to backflow, and ultimately the weak portion of the lymphatic starts to leak, and this is what happened to this patient. So what we did was we actually created a shunt that allows the lymphatics to drain to the vein distal to the obstruction. So in this case, we made 4 shunts, 2 in the ankle and 2 in the groin. And you could see that ultimately the lymphatics were able to drain to the vein distal to the obstruction. And this is what happened in 1 month later. We were able to clearly improve the chylothorax on the pleura. And then ultimately the patient removed the pleural tube and then ultimately was able to breathe normally. So this was a life-saving procedure. So understanding this, what is basically lymphedema is distal to the obstruction point, the fluid doesn't get cleared, and then it starts to accumulate in the tissue. And this is what lymphedema is. And sometimes it has to do with a clear technical obstruction, or sometimes it has to do with dysfunction, or in the elderly, often with degeneration as well. So these fluid starts to accumulate where the lymphatic vessels are, and these are in the subcutaneous fat. And once it accumulates, this is what happens clinically. This is what it looks like. And you could see sometimes bilateral, sometimes unilateral, in the lower extremity after gynecological cancer or urology cancer, or in the axilla after breast cancer, or even congenital, which is called primary lymphedema as well. Now, secondary lymphedema is lymphedema where we have a clear cause. But for primary lymphedema, it's something that we don't clearly understand. Sometimes it happens congenitally, where you're born with it, or sometimes it could happen in young adulthood, or sometimes it could happen in adulthood as well. But in our minds, although we need to confirm this with more research, I think there are 3 types of primary lymphedema. One that has agenesis of the lymphatic system. One, there is some lymphatic system, but it's dysfunctional. Somehow the lymphatic vessels are not functioning the right way. And third, I think it's a mix of agenesis and dysfunction. So that's how the primary lymphedema is defined. And sometimes these kind of surgical solutions to recover the physiology works, and sometimes it doesn't. If it's lymphatic agenesis, of course, surgical solutions will not work. Nevertheless, what is fortunate from the surgical perspective is that more than 95% of lymphedema are all due to secondary causes. And the secondary causes can be frequently from lymph node resection after malignancy, or from trauma, even from DVT, radiation, and even from severe infection, such as mosquitoes. Filariasis is a very common cause in some parts of Asia, and these are all causing lymphedema. Now, let's step back and think about the physical entity of the lymphedema. It's basically a towel soaked with water in our fat. So it's like a towel soaked with water, but the fluid is accumulated in the fat. So what do we do when the towel is wet? We squeeze it, and we squeeze it so the water can be removed from the towel. The same principle applies to lymphedema. Basically, we start with high pressure garments or high pressure bandages. And when we do that, we squeeze or push the water from the fat toward the proximal side where the lymphatics are relatively better. And this is what the physical therapy or compression therapy is all about. Now, the good news is that 85 to around 90% of the acute lymphedema, just with compression, is able to resolve the problem and doesn't go on to be a chronic, long-lasting lymphedema. So early identification and early diagnosis of lymphedema is critical, along with the right physical therapy. And when these physical therapies don't work, then we should consider a surgical solution. And this is why the multidisciplinary approach, partnering up with physicians, especially with rehabilitation, vascular, or imaging, is so important for early diagnosis and the right management, and ultimately sometimes to the surgical management. And again, the lymphatic fluid accumulates in the fat. So what do we do? And what happens if these accumulation starts to not be able to be cleared, or it starts to accumulate? And what happens is that it starts to leak through the skin. And this is what you see frequently in a very aggressive, progressed lymphedema. As you can see here, because of the repeated infection, and the fluid drainage, a lot of the tissue becomes fibrosed, and still you see these kind of leaking through the normal skin. And this is why early compression is very important to make sure that it doesn't progress to these kind of conditions. And there's so many complications involved in lymphedema. 1/3 of the patient actually has recurrent cellulitis of the extremity. And this is troubling because sometimes the patient is on antibiotics for the whole year. And ultimately, this could even go on to become sarcoma, not to mention the disfigurement of being an elephant leg, and even tragically leading to some amputation scenario. And again, to see the lymphedema patients, you need a multidisciplinary team who knows what they're doing, and then basically find a solution for the patient. Now, through this kind of multidisciplinary work, we're able to identify patients with high risk, especially for breast cancer, the ones who are undergoing radiation therapy, the ones who have more than 5 lymph node dissection, and the ones that occur relatively 1 year after the lymph node resection. We know that these are very high-risk patients, and we keep a keen eye and see whether or not the rehab works. And then if it doesn't, the patient is referred to plastic surgery. Now, I mean, you could argue, why do we need surgical intervention? Compression works very well. And yes, that is true. But the problem is, in some parts of the world where it's just too hot or the patient's too lazy, you cannot imagine the pain of wearing these very tight, high pressure garments through the rest of your life. And this is why a lot of reports have been associated with poor social well-being, depression, and not to mention the patient's ability not to go back as a normal component of the society. So our goal has always been finding a way we could overcome the pathology and reconstruct the normal physiology, and ultimately improve the quality of life. And that's where the role of plastic and reconstructive surgery comes in for lymphedema. Now, this phenomenon is not something new. Like I said, it could also happen from infection. And early reports, even up to 4,000 years ago, actually have documented patients with lymphedema in the ages of the pharaohs. Now, in the past, because we didn't understand much about the physiology or the pathology, but they understood that it was expanding in the fat region, a lot of the early stages of early surgical interventions prior to having better knowledge was focused on removing the fat or focused on squeezing the fluid out. And this kind of approach is still valid today. Now, remember, where does the fluid accumulate? It accumulates in the fat. So theoretically, if we remove the fat, then the chances of the fluid accumulating would decrease. So here's a patient that underwent debulking surgery, and you can see in some components of the fat, it recurred with lymphedema. So what we did was we removed that recurred portion, and then we excised it, we repaired it. But however, this patient needs to undergo a compression therapy for the rest of his life. Now, an extreme form of decompression or removal, debulking surgery is what so-called the Charles procedure. So under the tourniquet, everything is moved above the deep fascia. So all the fat is moved as much as possible. And then skin graft is harvested and the patient is back grafted. So now you see that the patient will not have lymphedema for the rest of his or her life. But the problem is you cannot go out sunbathing, or the patient may able to wear at least normal pants, but there's still a problem of going back to society with short pants and ultimately becoming a part of the society. And this is why nowadays debulking is now more addressed with liposuction, where we try to suck as much fat out using these liposuction units and ultimately have a much more better cosmetic appeal. Now you can see that this patient, when the patient was young, a few months after birth, patient was diagnosed with congenital lymphedema. So what we did was we did the imaging study. Unfortunately, we were not able to find any lymphatic vessels. So we started to liposuck, and this is relatively well maintained at 5 years of age. Now, early when the lymphedema is aggravated, when there's cellulitis and when there's a lot of fluid, we just make incisions and we could actually drain out the fluid for the time being and ultimately try to maintain a reasonable volume. But again, these patients will need some form of compression for the rest of their life. So these debulking procedures, with the exception of the Charles procedure, will need some kind of conventional compression therapy for the rest of his life. So how can we address in improving or having a more permanent or long-lasting result and recovering the physiology? And again, that's where the concept of physiological surgery comes in, which is lymphovenous anastomosis, which we talked about briefly, connecting the lymphatics to the vein or connecting the lymph node to the vein as well. So these are very typical lymphatic surgery procedures. Now, remember, where does the lymphatics drain? The lymphatics ultimately drain to the subclavian vein. So if we're able to create a shunt distal to the obstruction point, then theoretically the fluid collection would be far less. And that kind of concept is called LVA, lymphovenous anastomosis, creating a shunt, or lymph node to vein anastomosis, LNVA. Now, if you are not able to have the infrastructure to do LVA or LNVA, another physiologic procedure is replacing what is missing and basically taking a lymph node from where the complication could be much less by harvesting, and then ultimately transferring into the site where the lymph node was removed. And this is called lymph node transfers. Now, the early science also started to understand the pathophysiology of lymphedema, and reports as early as 60s have actually tried to create that shunt in the humans with lymphedema as well. But the problem is, back then, they didn't have the right capability and the imaging capability to find where actually these functioning lymphatic vessels are. And so once we're able to find where exactly the lymphatic vessels are, we're able to provide a surgery with a very high chance of success. And these imagings involved in lymphedema are lymphscintigraphy, MR lymphangio, ultrasound, indocyanine green, angiography, and sometimes even gamma probing. Now, this is a lymphscintigraphy where it shows the flow of the lymphatics is normal on the left side all the way to the groin, but on the right, there's no drainage. There's no clearance. This is a ICG, indocyanine green imaging, and you can see clear lymphatic pathway. in the earlier lymphedema, but the imaging is poor in the relatively advanced stages. This is MR lymphangiogram, and you could see that the deeper lymphatics are clearly seen in the MR lymphangiogram. But nowadays, the best way to actually find functional lymphatics in our hands is the use of ultrasound. And here you could clearly see the lymphatic vessels and these nearby vein, allowing us to do a much more better job in finding lymphatics and the corresponding vein that we have to do the anastomosis to. So ultrasound in our mind is one of the best modalities to find these functional lymphatics along with the nearby vein, and allows us to do the lymphovenous anastomosis as shown. We've published multiple works. This new imaging allows us to find the functional lymphatics and ultimately provide a physiologic surgery to allow the flow by creating a shunt between the lymphatics and the vein, and allowing the flow, the accumulation of fluid to get better. So that's lymphatico-venous anastomosis. And when you make that shunt to the lymph node, it's lymph node to vein anastomosis, and sometimes the lymph node flap. Now, thanks to this gentleman, Dr. Koshima from Japan, with understanding of smaller structures like lymphatic vessels with higher magnification microscopes, smaller micro instruments, smaller sutures, we're now able to find these lymphatic vessels and then connect them into the vein. So why is this important? Because in the past, lymphedema, when they try to do lymphedema surgery in the 60s and the 70s, they all started to find lymphatic vessels in the groin. However, the degeneration occurs from where the blockage is, and then the degeneration occurs distally. So oftentimes in progressed lymphedema patients, because of the degenerated lymphatics, they were not able to do a successful lymphatico to venous anastomosis. And now with the right imaging, and this is how we do surgery. So here underneath the skin, we open up, and we use a special dye to find lymphatic vessels. And once we find these lymphatic vessels, we dissect them with the right instrument. And this is a 6-0 suture, by the way. So you could imagine how small the lymphatic vessels are. And then we suture them to a vein. And then the high pressure lymphatics is able to flow in to the vein. So after the anastomosis, this is around 0.3, 0.2 millimeters. And you can see in a bit, we try to do the other one. And while we're doing the anastomosis for the other one, you could actually see the vein turning yellow right here, which means that there is a passage of flow. So how does this work? It works by utilizing the pressure gradient. So what happens to the lymphatics when it's obstructed? The pressure goes up. And what happens to the vein? The pressure remains the same. So the high pressure lymphatics drains into the low pressure vein after doing lymphatico-venous anastomosis. The vein, when lying down, the pressure is low. And in the distal, the pressure is high. The proximal, the pressure is lower. In the leg, venous capillaries, when you're lying down, it's 20 millimeters mercury. In the right atrium, it's 2 millimeters. However, when you're standing up, these pressure could increase all the way to 110 millimeter mercury in the leg. However, when we start to walk, this venous pressure decreases because of the pumping action provided by the muscle contraction. And this is why, in order to have a better lymphatico-venous flow with the compression, when you walk, the vein pressure drops, allowing a greater pressure gradient. And this is why after we do the LVA, we ask the patient to do compression and then walking. The lymphatic pressure in normal situation is around 12 to 70. However, when it's obstructed, it increases as high as 200 millimeter mercury. And this is exactly how lymphatico-venous anastomosis works. High pressure lymphatics to flowing into the low pressure vein, and that's using the pressure gradient. Now, we talked a lot about selecting the ideal lymphatic vessels, because obviously it has to be functional, it has to be large enough, And as you can see here, as the disease progresses, the lymphatics often degenerates. And this is why finding a functional lymphatics with the right imaging is critical. And so the deeper you go, the larger it becomes, and you have to make sure it's not degenerated. And that's how we find the lymphatic vessel and do the LVA. Now, you must also find the vein, corresponding vein, to do the anastomosis. And that's how the lymphatico-venous anastomosis works. And ultimately, it drains to the vein. There's many ways to do the anastomosis. End-to-end, side of the lymphatics to the end of the vein, side of the vein to the end of the lymphatics, and even side to side. However, our literature actually shows that by doing a LVA on the side of the lymphatics in a progressed lymphedema patients, because of the dysfunctional valves, now you're able to collect fluid from the proximal as well as to distal and go through and collect through the vein. And that's how LVA works. So here's an example of how we provided a side-to-end lymphovenous anastomosis. And you could see when we contract the muscles a little bit, you can see the fluid draining from the side of the lymphatics to the vein and clearly making the LVA work. We've also published multiple work showing that the side of the lymphatics to the end of the vein has a significantly better clearance capacity compared to the end-to-end anastomosis. And this is the follow-up result after a few years. The same principle applies for genital lymphedema. After LVA, you could see that the volume has decreased significantly within the first 6 months, and we're able to provide a solution. And even with more progressed lymphedema, as long as we're able to find a functioning lymphatics, we're able to do these kind of surgery and have the patient from a discomfort, dysfunctioning, and disfigured extremity to now a relatively reasonable extremity and without even any compression in this patient here. So here, after the surgery, this is the acute result after a few weeks. And again, multiple publications have supported this idea, and that's how basically the lymphovenous anastomosis works by flowing from high pressure to the low pressure vein. We were also able to prove that as we're doing LVA, the incidence of a very severe complication like cellulitis increased significantly from an average of 2.6 to less than 0.12 per year. Now, the other modalities of the lymph node to vein anastomosis, basically the same principle. And then, of course, there's the lymph node flap, which we harvest the lymph node from other regions of our body and replace what is missing. These are the two other physiologic surgeries that is available for the lymphedema patients. However, because of time, we're not going into the specifics. So we talked about what is lymphedema, why is conventional therapy working, what are the treatment options for lymphedema, and what is the surgical treatment option. We also briefly talked about why is teamwork important. Now, remember that this kind of lymphedema surgery has only been less than 2 decades probably that we've been really actively doing. And it takes a lot of work. And as you can imagine, doing surgery in a 0.3 millimeter vessel, it needs a lot of learning curve. It needs a lot of time to do a small vessel surgery. But if you are passionate enough, if you invest time, go through the learning curve, remember that anybody is able to do it. Now, we're having new data, new evidence as we speak. It's an ongoing science, but what's really interesting is that we're now, there's a consensus now knowing that this actually works to help patients with lymphedema. We don't know much about lymphatics-related disease either. And there are now some exciting reports of even talking about how the LVA or the shunting process may help other disease related to lymphatic disorders, such as chylothorax, which we talked about briefly, protein-losing enteropathy, even dementia, which is related to the obstruction of lymphatic flow in the brain. But the most important and exciting thing is that there's so many lymphedema patients out there. There's 300 million lymphatic patients out there. and 1 out of 1,000 primary lymphedema patients in children. And what's really exciting is that we're now able to give hope to these patients and say, we have a possibility, a potential to help you with your lymphedema problems with surgery. And of course, this is an exciting field. It's a new field as for plastic surgeons, as microsurgeons, to be involved in helping the patients with lymphedema. I hope I have helped you understand what lymphedema is, understanding the pathology, and using to recover that physiology in finding surgical solutions. I apologize that I'm not there in person, but I do look forward to visiting your country someday and hopefully meeting you in person to share the latest updates on lymphedema surgery. So with that, thank you very much.